Hey guys, I'm Wes, Community Education Specialist with Cypress Basin Hospice. Welcome to Cypress Basin Hospice Education Series, Hospice in the Nursing Home, Part 1. Cypress Basin Hospice is your community-owned, nonprofit, CHAP-accredited, Christian faith-based hospice, serving Northeast Texas since 1986. With offices in Mount Pleasant, Paris, and Sulphur Springs, we're able to better serve our 16 counties. Being nonprofit, we're able to serve anyone in our area that meets hospice criteria, no matter insurance source or lack thereof. Neither does age play a part, as we're the only hospice in Northeast Texas to serve pediatrics. What hospice care is? Hospice care is a Medicare benefit, and as such, there are many rules and regulations that hospices must follow. Hospice focuses on comfort and quality of life for individuals and their families when a cure is not available or not possible, even with specialized care and services. Hospice provides support and care for those in the last phases of a life-limiting illness, 6 months or less, as diagnosed by a physician. Hospice recognizes dying as part of the normal process of living, and hospice also affirms life. It offers a highly trained and dedicated team of individuals to support the patient and their family with their physical, emotional, and spiritual needs. Hospice began in 1974 in the United States with the foundation of providing services to those who can no longer benefit from curative treatment and have a life expectancy of 6 months or less. It is usually delivered at home or nursing facilities and occasionally receives care in hospital settings. What hospice care is not. Hospice care is not about giving up, but rather it's about living your best life in the face of a terminal illness. It's not about hastening or postponing the dying process or death. It's not a place or a location of care. It's not the same as home health, but rather, hospice is a philosophy of care, and it is a special kind of care. It is palliative care. It is holistic care. It is patient-centered, family-inclusive, and compassionate care. There are levels of care inside of hospice. Routine home care occurs wherever the patient lives. Respite care is provided in contracted nursing facilities, and there is a criteria that must be met as assessed by the IDG. The patient may stay up to 5 calendar days. Continuous care occurs wherever the patient lives. It is better known as crisis care because it is symptom management that can be handled at the home setting or even the nursing facility setting. However, it cannot be delivered when patients are under general inpatient level of care or on a skilled nursing floor or skilled nursing stay. General inpatient care occurs at a contracted hospital or a skilled nursing facility, and they must have a 24-hour RN on-site coverage or an inpatient hospice facility. And of course, criteria must be met for symptom management to be occurring that cannot be managed at a lower level of care. Today we're going to talk about hospice care in the nursing facility. Hospice care provided in a nursing facility setting can be routine home care or respite care. The Hospice Interdisciplinary Team, or IDT, is responsible for developing and managing the plan of care. As long as the patient remains on hospice, the focus will continue to be comfort care. Respite care primarily is provided for relief for caregivers. It allows the hospice patient to be moved into the nursing facility in order to give that caregiver a break and those needs be met by the nursing facility, those daily changes of wound care, the incontinent care, those kinds of things. The day-to-day needs of the patient are met at the facility by the facility staff. This is a provision under Medicare for a maximum of 5 calendar days. Routine home care also can occur at the nursing facility, and it is provided for those residents whose home is the facility. During respite care, the hospice provides arranging transportation to and from the facility, whether that's an ambulance transport, the family's able to take them, or even if the nursing facility's van can pick the patient up. We arrange all of that and coordinate with everyone to make sure that the patient is able to get to the facility safely. Hospice also obtains the physician's orders for care, as well as the facility administration approval for that respite care stay. Hospice manages that plan of care. continue to make sure the patient stays as comfortable as they can possibly be, and making sure those medicines are working effectively for that. Hospice nurses visit on a routine frequency, whatever their frequency was at home. They don't necessarily increase or decrease their visits. Once they come to respite, they continue to see them on their routine scheduled visits, as well as the chaplains and social workers, as part of that interdisciplinary team, continue to come and make their routine visits as well. If the patient had a hospice aide, then they would continue to come and take care of them at the facility as well, as far as their scheduled baths. Also, payment to the nursing facility for room and board at the contracted rate. Hospice takes care of paying for the room and board bill while the patient is in respite care. During respite care, the facility provides recognition and support of the patient's chosen end-of-life care. Also, they take care of medication administration. You guys want to be able to do that. We bring you the medicines, you have them on your cart, and then you're able to give that patient their meds off the MAR that's provided. And that way you don't have other people coming in and taking over your med cart, which you don't want that to happen. So you guys also provide 24-hour nursing care, the personal care needs, and again, if they had a hospice aide at home, they will come and see the patient at the facility on the scheduled days that they had seen them at home. You are responsible for contacting the hospice for any changes in patient condition, facility staff, patient family concerns, orders written without hospice staff awareness, any orders for diagnostic tests or procedures prior to the test or procedure being done. So anything that comes in that is different or new, contact the hospice. You guys also would provide 24-hour visiting hours, including visits from children, occasional arranged pet visits. Now, of course, during a global pandemic, we're going to err on the side of caution and follow your guidelines and your strictest rules as far as visitors and those kinds of things as well. During routine home care, the hospice provides much the same as it does during respite care, except for now the patient is going to be living there permanently as opposed to just visiting for 5 days. We're going to obtain those physician orders. We're going to manage the plan of care. We're going to visit on that routine frequency. We're going to assess potential needs and those kinds of things and make that care plan fit that patient as to what they need. PRN visits are available. Visits from other interdisciplinary team members per the patient's hospice plan of care. That's social worker, chaplain, hospice aides, all of those things. We do collaborate care from the hospice staff to the facility, and we do try to attend care plan meetings. During routine home care, the nursing facility provides, again, much the same as you do during respite care, recognizing and supporting that patient's chosen end-of-life care, medication administration, 24-hour nursing care, contacting the hospice with anything that comes up, any changes, 24-hour visiting hours. Again, global pandemic, we're going to err on the side of caution and follow your facility's protocols on visitors. Teamwork, communication. In order for the patients to receive the maximum benefit of hospice and care in the nursing facility, it is imperative that the hospice and the nursing facility communicate with one another. If one agency is saying one thing and another agency is saying the other, then that causes confusion for that family and it causes confusion for the patient, and there's some misunderstandings that can grow and cause distrust between either side. And so instead of doing that, we encourage communicate. We tell our nurses to talk to those charge nurses, talk to the DONs, the ADONs, and make sure that everybody is on the same page and everybody is doing their best to try to help this patient have the best day possible. And so when we all communicate the same, it really helps that patient and their family to have the best possible situation in probably one of the worst situations of their life, is the death of a loved one. And so that way we can help ease that suffering and discomfort for both the patient and the family. Coordination of care. This is something that you guys hear of when state comes to see us, is that this coordination of care is a big deal, and we've got to do this with the nursing facilities and our hospices. Communication. Again, communication with the patient, with the family, with the hospice, making sure everybody is on the same page. Next, I've got facts versus feelings. What do I mean? Let the hospice nurse know these facts. When was the patient's last bowel movement? Let them know for med refills. You know how many med refills you're going to need because you're supposed to have at least 3 days of medications for the patient in the facility at all times. Fact. Falls, skin tears, breakdown, skin breakdown, those kinds of things. Let the hospice nurse know about those. Functional status. If the patient was walking down the hall 3 weeks ago and now they're using a walker or they're in a wheelchair, that's some decline that you need to let the hospice nurse know about. Also, what are feelings? What do I mean by feelings? Well, the patient's doing okay. Well, what do you mean by the patient's doing okay? I know you see the patient every day, and so to you, they may not have any major decline, and since you've been seeing them over the last 6 months, a year, they may be doing okay with where they're at right now, but they may not be doing as okay as they were 6 months ago, a year ago. Or feelings like, the patient's just going downhill. I can't really put my finger on it, but as a nurse, you know that something's going on with those patients, and you know that something's going on with your resident when they just can't seem to get back over the hump, if you will. And so those kinds of feelings are very important to express to that hospice nurse as well as to the families. Right now, I know with the global pandemic, the families can't come and visit as often or at all in a lot of facilities, and therefore they are really relying on you guys as the eyes and ears to know what's going on with their loved one. And sometimes we've got to be brutally honest with our family members and let them know, hey, Miss So-and-so she's going downhill. I can feel it. I see we're doing everything we can do, but she's just not getting better. She's not responding to therapy. She's not responding to this treatment or that treatment. And it may be time to have that conversation that, hey, maybe we do need to have hospice come in and talk with them, and just have them have hospice come and lay their eyes on them and see if they look like they may be hospice appropriate, and have that conversation with that family. Because 4 months ago when the pandemic started, it's hard to say that, well, no, Mama didn't need hospice then, but she may now, and they haven't seen her, so it's hard to make that connection. What else do we do when we coordinate care? Well, Cypress Basin, we provide a black binder with notebooks for you guys that has our care plan, our collaborative plan of care with you guys. It has our nurses' notes, our hospice aid notes, the DNR status for the patient, social work notes, chaplain notes. All of those things are there right at the nurses' station. The med list is also there. And we try to keep it very discreet per HIPAA so that somebody can't walk by and look at your charts as you see them in the back in this nurse's station here. You can't see Brenda Jones, Cypress Basin Hospice. No, we don't have that. We would have her initials BJ or JB and have a sticker with our logo on it so that the nurse knows and the hospice knows whose is whose and what and whatnot. Common misunderstandings. It's often thought that hospice is end-of-days care, whereas hospice is actually end-of-life care. The requirement for Medicare is that a doctor has to have given a 6-month prognosis. 6 months is a long time compared to 6 hours or 6 days. It's a lot longer end of life as opposed to end of days. And in one of my other videos, I'll talk more about end of days versus end of life. Myth: hospice starves patients. The fact of the matter is, hospice encourages patients to eat as long as they can possibly eat. We encourage, but we never force. Because when you force somebody to eat who has lost the physical function of their throat to be able to swallow, you really risk aspiration pneumonia, and aspiration pneumonia on top of stage 4 cancer or on top of end-stage CHF or COPD is really just adding insult to injury. And so we encourage patients to eat as much and as long as they can possibly eat, but never try to force them to eat. Myth: hospice uses medications in inappropriate amounts in order to hasten death. Absolutely not. Hospice does not euthanize patients. Myth: hospice patients must have a DNR to be on hospice. In fact, that's absolutely not true. It'd be a violation of the patient's rights. The patient has the right to choose to be a DNR or to be a full code. And if a patient's a full code, then it is absolutely their right to do so, and we will honor that. And of course, in the facilities, what do you guys do when a patient starts going down who's a full code? Send them out. That's right. And that's what you have to do, because unless you want to sit there and work on them for 30 minutes to an hour before the ambulance gets there, absolutely, you want to go ahead and get them ready to go and ship them out. That effectively gets the patient discharged from hospice for seeking aggressive treatment if they get sent to the ER for life-sustaining aggressive treatment. Commonly used medications in hospice: we do use morphine for pain as well as for shortness of breath and respiratory distress. We like morphine, the liquid, because it is fast acting. It goes under your tongue or in the buccal lining of your cheek, and it is absorbed quickly, and therefore it works quickly. But it also gets out of your system quickly. So it helps with pain, yes. It also helps with that shortness of breath because of the fact that it's a vasodilator and opens up those blood vessels and helps that your lungs to slow down a little bit and take slower, deeper breaths, getting more oxygen throughout your body. We use Zofran for nausea and vomiting. We've also used Phenergan and Haldol and those kinds of things in the past, but we use the Zofran now mostly because of the fact that it's not overly sedating and is pretty effective most of the time. Methadone is a great medication that we use for chronic pain for multiple reasons. One, it has less side effects than some of the other opioids, less constipation, and once it's built up in your system, it has less of the sedating properties, as well as it is the only long-acting opioid that can be crushed and still maintain its long-acting properties. So if you've got somebody who's taken MS Contin or OxyContin, you can't crush those because they're enteric coated. But once you get to the point with methadone, if somebody needs their medication crushed, you can crush it and it still maintains its long-acting status. It also comes in a liquid, which is helpful for some of those patients who can't swallow those pills or can't tolerate the crushed pills even. Lorazepam, we use it for anxiety and restlessness. We also use it for shortness of breath along with the morphine, and as well as for pain along with the morphine, sometimes to help keep patients comfortable for longer. When that morphine doesn't seem to last as long, the lorazepam seems to kick in and help helps to sustain that pain relief. It's an adjuvant. I have noticed over the years that some folks have a adverse reaction to lorazepam, not an allergy, but rather it seems to key them up or make them more hyper or bounce off the walls, if you will. And for patients like that, I've seen Xanax, alprazolam, and Valium work very well for patients that the lorazepam does not seem to work well for. And we do use that from time to time. Atropine eye drops, we use that for excessive secretions. Whenever we get, you've heard of Shane Stokes breathing, and you've heard of the death rattle, the all that wet right in the back of their throat. We use those eye drops sublingually to help dry that up. We're also using hyoscyamine tablets, which is anticholinergic, to help dry up those secretions as well. The questions that I want you to ask yourself is, who in my facility is not going to be here in the next 6 months? Whatever holiday party you guys are going to be having, Christmas party, New Year's, Valentine's party, 4th of July, whatever's coming up in the next 6 months, who in my facility is probably not going to be here? Okay? Who keeps getting shipped out to the hospital for recurrent infections? Who keeps getting pneumonia over and over again? Who keeps having CHF exacerbations? Who keeps having multiple UTIs? Who is it that's, quote, going downhill? Okay? Think about who those are. Do you have someone in mind? Maybe it's one person who fits all three. Maybe you've thought of 3 different people. These folks need a hospice referral. You say, well, Wes, they're not hospice appropriate. Well, they may not be hospice appropriate yet, but they need to get that idea going, and they need to have the options out there. Do we want to continue to go down this road of trying with very futile fixes, or do we want to have a quality of life that is much better than having to go back and forth to the hospital all the time? Maybe you've got that patient that I don't want to go anywhere. I don't want to go to the hospital. I don't want to do nothing. They may not have anything going on, but they need a hospice referral too because of the fact that they don't want aggressive treatment. They need to know what their options are as far as when it gets down to time, who they need to talk to. Thanks for watching this video presentation. If you have any questions on this video or would like to receive further instructions on this or another topic or schedule a live and in-person in-service for your group, please give us a call at 903-577-1510. For Cypress Basin Hospice, I'm Wes Smith.